You walk into your patient's room, 54-year-old fresh post-op, is complaining of pain at a level of 8 out of 10, respiratory rate's only 10, and O2 sat is 92%. They're grimacing, guarding their surgical site, and asking you, can they have something for pain? You notice the slow breathing. You notice the borderline O2 sat, and you notice their opioid naive status. But you also have a provider order of hydromorphone 0.5 milligrams IV every 2 to 3 hours for severe pain. So what do you prioritize? What do you do next? So here's where students often struggle. There's two truths that are colliding. On the one hand, you do have a patient with real pain that needs to be treated. And on the other hand, you have a medication that can certainly cause or worsen respiratory depression. In school, the focus is often a long list of side effects from opioids. There's not a focus on clinical judgment. But here in this situation where we're weighing two options, this is where clinical judgment matters most. Before we act, we pause. And this is not because we're delaying care. It gives us space to think. This one step prevents more opioid-related complications than anything else. So let's apply this first step in the framework, pause. What do we know? We know that the patient is reporting pain, but we also know we have a respiratory rate that's low, an SpO2 that's borderline, an opioid-naive patient, and we also know that opioids hit the respiratory system hard and fast and can really cause respiratory depression. If we go ahead and give this hydromorphone now, we could have a respiratory rate that drops from 10 to 6 in a matter of minutes. As we prioritize the second step, we're always going to prioritize breathing over pain. We're going to move right along to the third step, which is plan. So we're going to notify the provider of all objective data. We're going to make some suggestions, such as lowering the opioid dose or providing alternative solutions. We also want to consider adding some supplemental oxygen, and this is probably per protocol, but if not, we can get an order for that as well. And lastly, we have to reassess that breathing because things can change in a moment's notice. So as part of your SBAR, you might say something like this. I have a 54-year-old patient who is a fresh post-op, and he is an opioid-naive patient. He has a respiratory rate of 10, an O2 sat of 92, and I'm calling to request some changes such as alternative medications or lowering the dose. In this visual aid, Tessa is showing us the opioid safety triangle. She's pointing out how being opioid-naive, which is somebody who's not taking opioids on a regular basis, having a low respiratory rate, and that borderline SpO2 all together combine to really add up to a major safety risk. Let's add a little nuance. Let's say we have a couple conflicting cues going on. The first one is that the patient says their breathing is fine. So that is subjective data, and it does not override the objective data of the pulse ox and the respiratory rate. And here's another conflicting cue. Well, the doctor wrote the order, so it must be safe, and the pharmacy approved it, must be safe. No, no, no. Nurses always have to check first. We can't assume that just because there's an order that it's a safe thing to do at that moment in time. You may not realize it, but patients can have subtle deterioration right before your eyes. You could have a respiratory rate of 10 that goes down to 9, 8, 7, 6, right while you're talking to the patient. This is why it's important to use our 4-step framework of pausing, assessing the trends right away, prioritizing breathing over pain, planning to intervene early, and to reassess often as our prove stage. This is going to possibly prevent this patient from going into respiratory distress. And here Tessa has a second visual aid for us today. She's really just showing us this trend that I just spoke of. See, IV medications act really quickly, and even small amounts of IV medication will immediately start circulating throughout the entire body and will have an immediate effect. So, see, if we had given that IV opioid without pausing, the patient could have slipped quickly into severe respiratory depression before we even had a chance to recognize the decline. This is how confident nurses think. You're not just administering medications. You are protecting airways, anticipating risk, and making wise decisions that are going to protect your patient in the long run. Overall, you are building a clinical identity of clear confidence. Wrapping up our session today, Tessa has a visual aid that shows the 4 P's in action. This is a quick map showing us how to pause, prioritize, plan, and prove. If you want to go deeper into prioritization, check out some of the links in the comments section or check out the playlists on my channel. And be sure to join Tessa and I again next week for another Deep Dive Sunday.